Good day and welcome to this continuing series in videos from the Practice Protection Committee. I'm Pat Bailey, Medical Director for Advocacy in the DC office, and I'm pleased to be joined today by Dr. Michael Sarap, who is a private practice general surgeon and the chair of the Rural Surgery Advisory Council. Dr. Sarap is in practice in Cambridge, Ohio, Guernsey County. Mike, welcome. Pleased to have you with us here today.
Thanks, Pat. I appreciate the opportunity to do this interview and talk a little bit about private practice surgery.
So, Mike, let's start off by telling our audience a little bit about yourself and about your practice.
I've been in private practice for 33 years in the same rural southeastern county. I've had 2 or 3 partners along the way. This is part of Appalachia, sort of on one of the lower rungs in terms of socioeconomics. A lot of disadvantaged folks here where I practice. We've been, like I said, 2 to 3 partners, and so that means about every third night and every third weekend call. Our town itself is about 15,000 and the county is about 40,000. But the area in southeastern Ohio is a little bit more like the northern plains perhaps, or the west, where we have 7 counties locally around us that don't have a hospital. And there are 2 other counties that have small critical access hospitals with not a lot of services available. There's no level 1 trauma center. So our hospital is really a nice facility. It has 80 beds. We have 14 ICU beds. We have a census usually around 30 to 50. And our medical staff contains ortho, ENT, urology. We have pulmonology, critical care. We do in-house dialysis with nephrology consultants. We do low-risk cardiac caths with cardiologists. And we have a full-time medical and surgical oncologist. And we do have a freestanding cancer center that actually is, so we're opening a brand new building January 1st. We're very proud of that.
Yeah, that's very exciting. In a town of about 15,000 and a county of 40,000, you mentioned there, describe to us what kind of a caseload and case mix that you get with that large catchment area in a small city.
We do have a really true broad-based sort of practice. I do personally about 300 or more surgical cases in the operating room. I do about 1,200 endoscopies a year. I've gotten a huge practice built up in 30 years for screening colonoscopies and diagnostic and therapeutic endoscopy. And our practice in our office is not a white coat suit kind of an office. It's a working office. We do all the dermatology and skin cancers in a farming community. That's a big deal. And so we do about 500 or 600 procedures in the office. We have privilege to do general vascular. We do some thoracoscopy. We do all the trauma. We do have ENT, and so we do some thyroids along with them. We share them. We do carpal tunnels. I do pacemakers. The cardiologists in town don't place pacemakers. They decide who needs it, and I put them in. We do a fair amount of advanced laparoscopy, which includes the hernias. We do laparoscopic common duct exploration. We do lots of anti-reflux procedures. And so we do a pretty advanced endoscopy service as well. We do ERCP, and we do the full range of reflux type workup, including pH manometry. We also do PillCam that we get sent from several counties around. And so it's pretty extensive endoscopic and general surgery service.
So, Mike, shifting now to the business aspects about, how do you run your practice? What's your model?
The practice is run pretty much like a standard old-fashioned private practice. Its compensation is incentive-based, so we all equally share the expenses, pay the bills at the end of the month, and then your salary is based upon your receipts, how hard you work, how much you bring in. In addition, we have a very nice service agreement with our hospital that allows us additional income. We do a wound care clinic in conjunction with the nurse practitioner. We cover call, obviously, do trauma. We put central lines in for the hospitalists, and we do a fair amount of committee work. When I came to this practice, there was a fairly old office building, which we still have, and I suggested that they sell that, my partners sell that to the hospital, and so we've locked in really a nice lease for a number of years. And so our practice really doesn't own very much, basically the furniture and a little bit of equipment. This allows us to run on a very lean type budget.
So in some of the previous Practice Protection Committee videos, Mark Ader has talked about and emphasized the importance of having a team of experts to help you manage your business. How do you guys in your practice accommodate that?
We do have a local attorney that helps us with our corporation. We have a local accountant that actually joined the practice of his father, who was the accountant before that. And we've been very fortunate to find a group out of Cincinnati that is a financial planner and pension fund group that has been very successful for us.
So talk to me a little bit about how your practice has evolved there in Cambridge over the years.
When I joined this practice in 1987, my two older partners were doing general surgery, gynecology, they were fixing hips, and they also had their own private practice of medicine. They weren't doing endoscopy and certainly weren't doing any vascular, and so I brought that to the community and clearly told them I wouldn't be doing any baby deliveries, I would not be doing any major orthopedic, and certainly not having any kind of a medical practice. Since that time, I've been able to recruit 4 surgeons to this community. 2 of them are currently partners, and another practices independently in the community. And the other one actually joined us for 5 years, knowing that was going to go to Africa full-time for missionary work and wanted a little broad-based training, and that worked out great for him. So how do we recruit? Well, we offer a first-year salary guarantee, and the hospital's been very helpful in helping us to meet that guarantee. The second year, the new hire gets on a 50% compensation basis. He makes half of what he would if he had a bonus as a partner. In the third year, he becomes a full partner, gets a 100% bonus, no buy-in, no other stipulation. When we do hire someone new, we just send them to the accountant's office and instruct them to open the books and ask any questions they want. So we try to be very transparent, and it's worked out pretty well for us. I've been a hospital board member for over 20 years, and that's helped rather significantly as well in terms of our relationship with the hospital.
Yeah, that point was really emphasized in one of our previous webinars that we did back earlier in the year, how important it is to have those good relationships with your hospital administrators, for sure. Turning now, Mike, to what we see sometimes in the lay press and even in some academic articles, they talk about lower quality health care at places that are outside of the tertiary and quaternary centers. What are your feelings about that?
Yeah, the quality thing is an issue. There are several communities perhaps that don't follow the standard of care, but I would think that's an exception. I think that the majority of small town communities, especially if they have fellows of the American College of Surgeons, care significantly about quality and the value that they bring to their patients. If you think on a national level and you count the number of Commission on Cancer accredited facilities and the number of level 3 trauma facilities in the country, they're literally in the hundreds, and clearly there are not that many big cities to fill those. And so many of the cancer accredited programs on level 3s are in communities my size, and they do great work, and they're evaluated and accredited by national organizations. My own institution, we've been accredited by Commission on Cancer for 30 years, the NAPBC for 10 years, and we had a 10-year experience with being a level 3 trauma center as well. We've had a very robust sort of independently run colon cancer screening and treatment program for over 20 years, and our breast cancer patients' benchmarks meet or exceed the national levels, and so we're very proud of the work that we do. Unfortunately, in small towns, there's no QI person in the hospital, or the surgeon's too busy to really do QI and for performance improvement. And so we need some help from the academics. And the University of Michigan has helped in that regard. They have done some really nice studies looking at critical access hospitals, the smallest of the small. And they looked at gallbladder, appendix, hernia, and colon surgeries. They looked at morbidity and mortality and cost, and the critical access compared very favorably in terms of morbidity and mortality, and actually were lower cost. If you look back at the Institute of Medicine, there's really a profound white paper called Crossing the Quality Chasm. It mentions 6 factors that go into quality. That would be safe care, effective care, efficient care, timeliness, care that is equitable, and patient-centered. if you look at communities, small communities and rural communities, I think that we can do great with the last four. Who better to be patient-centered and equitable, and we're caring for our neighbors and our coworkers. They're close, they're here. We have connections to the hospital. We can slip them in for a CAT scan and blood work quickly. And so I think those four, we can be superior to the big centers with all the travel involved and lost family time and lost work time by traveling to the big centers. Where we have fallen down is that we have been unable to actually prove safety and efficacy because we're time limited. We're running our practices. We don't have help from the hospital. And so I think we need some help with the academics in regards to this. And I think it'll show that we do great, safe, and effective care.
So in the interview that Mark Savarese did with us, he talked about missing aspects of academia and missing being able to teach residents while working as a rural surgeon in his first practice. Do you have any similar regrets or any experience with that?
Yeah, that was a great point by Mark Savarese. Being surgeons, we are all trained in programs where you learn from the person directly above you and all the other levels above you. And to suddenly quit being a teacher, quit being a mentor, leaves a big gap in our professional lives sometimes. And I think you can fill that in a small community. I'm a clinical instructor for the medical school surgery program at Dayton, Wright State. We have third and fourth year residents, surgery residents come every year, and they think it's a great rotation. We're on the clinical faculty of a medical school and a PA school, and so we have students all the time around us. I'm an ATLS instructor, so I go over to Columbus and teach classes there. And then through my involvement with the Rural Council of the College of Surgeons and my state chapter and the college, I've been involved in about 60 presentations across the country, including Australia and one in Canada, which just canceled because of COVID, talking about quality care, regionalization of care, rural cancer and trauma care. And I've also been involved on, I think, 16 or 17 articles in peer-reviewed journals. And I've been involved in clinical congress sessions for the last 7 years, either as a moderator or a panelist. You can stay academically very involved. I've been very fortunate to be able to write a couple of book chapters, one on GI bleeding and endoscopy, and this upcoming one that I spent a year working on in terms of quality and value that's going to be on surgical clinics of North America. My involvement with the college and the Commission on Cancer has been great. Current chair of the Advisory Council on Rural Surgery. I've been a governor. I've been on several committees for the college, and then several work groups as well. So it's been a nice run for me, and it's been very enjoyable.
Well, no doubt, due to your hard work and efforts and making yourself available to serve the college and serve the Practice Protection Committee, and we appreciate all of your efforts there, Mike. Do you think that surgeons can still make a living as private practice practitioners in small rural communities?
Yes, Pat, I really think you can make a living as a private practice surgeon in a small rural community. When you think about it, general surgeons, the average or median salary is $389,000. Gastroenterologists make a very similar type salary, and so do dermatologists. And so this hybrid rural surgery model, you bring in all these different procedures that you do in different specialties that you've been trained to do, including even pacemakers and ERCPs, and you can make a nice salary. This also, private practice also allows the kind of practice that you want or that you need at the various levels of your career. After 33 years, I began to feel really burned out. And so I tried to remedy that by taking a week off every month. I work much harder those 3 weeks that I am working, but it offers me ability to get away from clinical practice, do some things that are just for pleasure, and it's allowed me to extend my career. I'm not sure that as an employed surgeon they'd let me do that. My two younger partners also do a locums coverage for a small hospital in the next county. That increases their revenue as well. And then you really have to consider rural practice or small community practice in terms of lower cost of living. Things cost less here, houses, land. Lifestyle issues are really important. Our call is not that really stressful. We're not in-house. I can fish. I can go see the kids play baseball and still be on call and make it to the hospital very quickly. I live on 8.5 acres, got a little fishing pond. I can make it to the hospital in 6 minutes where there's no red lights. My office is right across the street from the hospital, and so I can be in office, go see an appendectomy in the emergency room, come back and see a few patients until they get ready and go back and do that without a big disruption. We're really not that far in the boonies. We're about an hour to 2 hours away from 3 major airports, so we can get away when we want to. I have to mention that there's certainly drawbacks to private practice, just like there are drawbacks to every surgical practice. Paperwork and administrative problems are a major issue. All the paperwork involved in MACRA for a very small improvement in compensation. Even mock every other year, I think, is excessive in terms of the paperwork involved and the time involved. Pre-certification has been a major quagmire. We have to hire people just to do this every single day. And I guess the least favorite thing from running my practice is human resources, the hiring and firing and disciplining staff and employment issues is something that I'd rather not have. And then lastly, I think there's a real emergency looming with the 7% cut, Medicare cut in January 1st. Private practices are already reeling from decreased reimbursements and salary from COVID, and this could be the death knell for many that are on the line, whether they survive or whether they fail.
Well, thanks for referencing that pending Medicare cut, Mike, and we would encourage everyone who has not yet to log on to surgeonsvoice.org and to take action by notifying their legislators of this and how that in a time of pandemic is not the right time to be cutting Medicare to critical surgical providers by 7 to 10%. Mike, what sort of advice would you give to trainees or surgeons starting in a new community about building relationships within their community and goodwill?
Yeah, I think that's a great question. There are things that you can do other than just hanging a shingle, putting an ad in the paper in terms of small communities and improving the goodwill. I think that as soon as you move to a small community, you become the local expert in cancer and trauma and accident prevention and new healthcare technology. So you're the expert in education. And so I think you should offer presentations to service clubs, get involved in local radio, TV, the newspaper. One way to start in a community is Stop the Bleed program. I went to a college meeting, brought this back to my community, and it spread like wildfire. We started with first responders, and it's gone to the churches, the schools. It's an absolutely great way to get involved in your community. But whatever interest you have, it can be firearm safety, cancer prevention. Get involved in education or community. Certainly a great way to endear yourself to a local community is investing in their youth. I think mentorship at every level should be something surgeons get involved with. High school kids, college kids, kids that are in medical school that come back, let them come in, let them shadow you in the office or endoscopy suite. We do still let students in the operating room once we know that they're mature enough. We have kids shadowing all the time. There's a great program that you should look into with the Scouts called Medical Explorers. It's a great program. It's like 5 weeks in a row, one night a week, and the hospital, different departments take the kids under their wing and do a little dog and pony show, if you will. We actually bring them into the operating room. We have 2 laparoscopic trainers set up. We have an intubation model at the head, so anesthesia shows them how to intubate patients, and we cut out little foam organs, gallbladders and appendixes and uteruses, and the kids help each other with the cameras and cutting and clipping, and they think it's a great opportunity to see what we do. In fact, the parents want to come now. It's been so popular.
Mike, what about civic organizations and service clubs? Any thoughts about that?
Yeah, there are some other things. Service clubs are a great way to meet other people in the community, other facets of the community. They're always looking for lunchtime talks, and obviously surgeons are ready-made to give those. Community screenings are great. We have, for many, many years, done skin cancers and breast cancer screenings. vascular screenings, and it helps the health of the community, but it also helps you to get out into the community and meet people. There are also community coalitions that you can be involved with. We have a great cancer coalition that we started because we found that we were very down low on the list of communities with many, many late-stage colon cancer rates. And so we got involved in patient education, physician education, and some reduced and cost-free colonoscopies. And we've just basically turned that statistic completely around. Board membership is great. I'm on a hospice board and the hospital board for many years. And then lastly, I'd really like to stress that any surgeon that joins a community ought to join their state chapter for the American College of Surgeons. It builds relationships with the academics, with surgeons at all different levels in your state, and it really is good for quality of care. It helps with transfers of patients. It helps with coordination of care with the big centers, and the patients benefit, and so do the physicians on both ends.
Mike, this has just been a wealth of information for folks today, and we really, really appreciate you providing this and taking time off and delaying your operating room this afternoon to come and do it. What sort of closing comments do you have for us?
Thanks for letting me kind of talk about my private practice. It's been a great run. I don't think private practice is dead. I think if you find the right practice with the right partners in the right community, and you work with your hospital instead of working against them, you can really elevate the care of your patients and the health care in your community. Maybe I just hit the sweet spot with my choices in my personal career, but I really believe there's opportunities in private practice in small communities that'll let you reach what I call that ikigai. It's a word that's been thrown around, Japanese word that means meaning of life. But it's something that you can do, something you're very good at, something you're passionate about, and it results in appreciation and respect in your community. We're not devalued in our community, and you certainly can get financially rewarded for what you're doing with a broad-based practice. And clearly, you do something the world really needs. Rural access to care is failing, and rural surgeons offer the ability to save lives and make people's lives much better. So, Pat, I appreciate the opportunity to talk, and thank you very much. Have a great day.
Well, Mike, thank you again, and we look forward to welcoming you back on another occasion to expound upon some of these points. In the meantime, we thank you all for joining us for this video series from the Practice Protection Committee, and we look forward to welcoming you back in the future. Good day.